Okay. Um, Thank you. I am not who was in the program originally, but I'm pleased to be able to present the results of a trial that we are, actually, we're still analyzing some of our results. This is my disclosure. This project was funded through an NIMH grant. Um, what we really were interested in doing was not another study looking at DBT and its efficacy, but looking two things. One, trying to understand mechanisms of action, and two, trying to see if it actually worked really successfully in a 6-month trial. And I think Joel Paris yesterday asked about the question about, like, when do you get the effects, like to Shireen Rizvi, who presented on her 6-month treatment in a training clinic. And so if you look at the original data from the Linehan study, the original data shows that all the changes occurred in the first 4 months of treatment. And then there is like one sentence in the end that the next, from month 5 to month 12 were used for consolidation. And so I wasn't quite sure, what consolidation means in the context of a 12-month treatment, but we were really interested in seeing if we could get an effect that was an enduring effect on suicidal behavior and self-injury in 6 months. Okay. So here are some of the aims that we had. Number one, as I mentioned, is 6 months enough? Number two, to determine if emotion regulation and impulsivity moderate treatment response, and if these measures change differentially in the two treatments. To determine if stress response changes differentially over treatment. And then to study changes in cognitive control using fMRI pre and post treatment. Now, I'm actually not presenting on that. Jen Silvers, who is in the next room presenting at this time, is talking about some of those data. So, our trial is to compare dialectical behavior therapy to SSRIs. And so it's a straight psychotherapy versus medication trial. So why did we choose SSRIs? It's actually a standard medication for people who have, when you first walk in the door and you want treatment for BPD, it's a typically standard choice, especially because major depression is a frequent comorbidity. The other reason that we chose this is there's a big body of literature that shows that there is serotonergic dysfunction associated with suicidal behavior, above and beyond the serotonergic dysfunction found in major depression. And if you look at the guidelines for treating people with BPD, you see that Soloff back in 2000 recommended SSRIs as a frontline, as did the APA guidelines. However, the NICE guidelines recommended no medication for BPD. And actually, just to kind of skip to the end, our trial is going to kind of support, at least for SSRIs, that SSRIs are not particularly effective. Why DBT? So we know the literature on it, but a 12-month treatment is labor intensive, and the original efficacy data, as I mentioned, showed effect at 4 months. And really, it's surprising, but little is known about mechanism of action for both treatment approaches. So what we did was we took males and females under 65. Participants were washed out of all meds except benzos and were randomly assigned to one of two treatment conditions, DBT or fluoxetine with supportive clinical management, with the option of switching or starting with citalopram or paroxetine. So one of the things that I think is really important here is they were washed out of all meds. These were patients who did not have, in the DBT condition, they had no medication except benzos. And in the medication condition, SSRIs except benzos were their only medication. So this is not like, oh yeah, well, we tried to get people off medication and as much as possible. So it's a pretty clear comparison. So we did baseline measurements, 2, 4, and 6 months, And then we did fMRI with 2 cognitive control tasks. One was the IAPS pictures, and then one was personalized memories. And we looked at the ability to control the reaction to them. So that is what Jen is presenting on. We did the Trier social stress test pre and post treatment to look at changes in that. And then we did EMA at 3 time points in treatment. And I'm not actually going to have time to present that data, but that data is so incredibly interesting. So we enrolled 111 people. Eventually, 42 were in the medication condition, 42 in DBT. So I'm just going to show you these tables here that basically show the demographics that the randomization worked. They didn't differ in terms of any of the important demographics. In terms of diagnostic variables, it's really important to note that 68% of patients had a comorbid diagnosis of major depression. This is extremely common in our samples. About half of them had current substance abuse. When they came in, they couldn't have substance dependence. A little bit less than half had childhood physical and sexual abuse. In terms of clinical characteristics, they were depressed. They met criteria. So you can see this was a pretty ill population. Okay, and they had current suicide ideation. 9.5 is pretty high. They had to have either a history of a suicide attempt or non-suicidal self-injury in the past 6 months, and then another one in the prior 2 years, and they had to have current suicide ideation. So they could either have current suicidal behavior or current suicide attempt, recent suicide attempt. So they didn't have to have a recent suicide attempt to get into the study, but more than 70% of them had it. Almost the entire sample had a past history of non-suicidal self-injury. And so our outcomes were, we looked at actual suicide attempts during the trial and then suicide events. And so I just put up here what our suicide attempt event measure was. We had, it's really important. Often studies just look at suicide attempts or they look at suicide ideation. But behavior is closest to other behavior. And so we try to get other types of suicidal behaviors. So we look at aborted attempts, interrupted attempts. So the interrupted attempt is stopped by somebody else, and aborted attempt is starting to engage in an act and stopping it themselves. The other thing is, which in the United States, we have no way of capturing this information, which is these micro overdoses, which my borderline patients do all the time. And so it's the only thing we started calling them taking more medication than prescribed, or taking more over-the-counter medication than they should take. They do it all the time. And so we started counting those things. But if you look at how people count suicidal behavior in our country, we don't have a way to count that. And then a suicide event was also serious suicidal ideation resulting in a psychiatric hospitalization or ED visit. Okay, so what did we find? If we look at suicide attempts, we find that the number of suicide attempts was significantly lower in the DBT group. The number of suicide events was significantly lower in the DBT group. In terms of non-suicidal self-injury, we found that, if you look at this, that there was when people got randomized, both groups had the same amount of having a history of self-injury, but the DBT group had a lot more self-injury, more episodes of self-injury. So what we did was we kind of controlled for the amount of self-injury, and then we looked at the results comparing medication, SSRIs versus DBT, and we found that the number of NSSI episodes during the treatment was significantly lower or in the DBT group or higher in the SSRI group. So were the SSRI superior in any way? And so, originally what we thought was, okay, so if somebody has an SSRI, on board, we should get kind of like, because treatment, psychotherapy takes a while to work and medications should theoretically work faster. And so, the initial hypothesis is that it was there would either be a greater improvement in depression or a faster improvement in depression, and it didn't happen. The only thing that we could find, and we looked and looked and looked, was there anything that the SSRIs were better at in this group? And there was a better initial improvement, so at 2 months, in the CGI scores than the DBT group. And that's it. Okay, so in the last few minutes, I just want to talk a little bit about some of the mechanisms. So we looked at, as I said, we were looking at emotion regulation and impulsivity, and so we gave the Barrett impulsivity over time. Now, the Barrett impulsivity is supposed to measure a trait impulsivity, but it doesn't. It changes over time. And so you can see here that at the beginning, they're both going down. The impulsivity is going down. And then in DBT, it goes down even further. And in the SSRI group, it ends up going up towards the end. And so DBT seems to be working by helping with impulsivity. In addition, we looked at the difficulties in emotion regulation scale and found that actually the same kind of thing happened. They both started out the same way. They both went down in the first couple months, and then in DBT, they continued to go down. And then we tried to look at what were the particular scales that were superior, and it was the non-acceptance of emotional responses, engaging in goal-directed behavior, and not surprisingly, the lack of emotion regulation strategies that showed superiority in DBT. Okay, so self-reported emotion regulation improves, but what about physiological responses to emotional stress? So we gave the Trier social stress test at the beginning and the end of treatment. This is a pretty ambitious thing to think that you're going to get a difference in a stress response and, a actual biological response. The Trier is a relatively mild social stressor. People come into a room in front of a couple investigators, those are 2 people from our lab, and do a kind of like a backwards addition test, and then do like a brief job talk, and then we collect cortisol levels over time. Not surprisingly, DBT and SSRI conditions didn't differ in pretreatment baseline cortisol or cortisol responses to TSST, which is what you would expect and want. Post-treatment results, and I'll just go to the end, controlling for pretreatment response, the DBT group demonstrated a greater reduction in cortisol response over time. So this was actually pretty surprising that DBT could actually have a physiological response. So what we're going to do next is we're looking at ecological momentary assessment, which is real-time assessment of affects, ideation, events, and behaviors over time. And so we did this at the beginning, midpoint, and end of treatment. And so I'm just going to show you this, give you examples of what EMA and suicidal ideation looks like over the course of a week in people with borderline personality disorder. What is so interesting is because this is what we actually think of about borderline patients, right? We think that this is what their ideation is like. And in fact, some people do have this type of ideation. However, we do have high stable ideation in this group and relatively low ideation that's pretty stable over the course of a week. And so what we're going to do is kind of take these patterns of ideation and see if we can kind of relate it to the cortisol response and also differential predictors of treatment outcome. Okay, so just in summary, DBT results in fewer suicide attempts, fewer suicide-related events, lower NSSI compared to SSRI treatment, 6 months of DBT is a feasible approach if self-harm outcomes are the target of treatment. And I think that that's important because that's what we looked at. Basically, I'm a suicide researcher. I'm interested in reducing suicide outcomes. And so if we want, and now I'm doing this other kind of job looking at implementation of suicide interventions statewide in our state. And so it's really important to find things that are actually accessible and implementable. And so one of the things that you can think about for this is, okay, so if you have somebody who is suicidal, you do this kind of like specialized treatment for 6 months, and then maybe we don't have to worry about what other kind of treatment they get. Maybe they can get a wide variety of treatments. SSRIs with good clinical management is not indicated in BPD if self-harm outcomes are the targets of treatment. Cortisol response to stress is lowered in DBT patients during treatment. It isn't changed in SSRI patients. And so we're thinking that maybe downregulating response to stress may be a mechanism of action in DBT. And then in the future, we're going to analyze the EMA, and then we're analyzing the fMRI data to see if we can find moderators of outcome. This is my research team. It's a great team. Beth is in the audience here. Beth Bratsky presented yesterday. That's it. Thank you. Okay, so any questions? Yes, Andrew.
Very interesting comparison group, and I'm wondering if you've got any data on the fidelity of the comparison group and the competency of the delivery of the structured management. Essentially what I'm asking is, is there an element of straw man in the comparison group that
yeah, so I don't know if everybody heard the question, but so Andrew is asking, like, is there, it's kind of like the TAU question, if you do treatment as usual, was I comparing DBT to basically nothing, a straw man? And actually, I really don't think that is true. The kind of clinical management that they had was terrific. And was extraordinarily careful. But I think that it was clinical management. It was not psychotherapy. And if you could call it a straw man, I mean, I understand what you're saying, but in the real world, medication is often the treatment that somebody with BPD is given. And so we wanted to see, okay, so is there a shot in the, to have any kind of efficacy for this particular medication for BPD? And so, I mean, I chose the clinician, the psychiatrist, who was extraordinarily careful, who saw this patient and did clinical management. And then they could get we had like a social worker who was like extra if they wanted some kind of like supportive care in addition. So we actually gave them kind of nice treatment, So I really think that this just kind of speaks to, the SSRIs alone, even with good care, good clinical care, are just not the thing. If this is the outcome. And actually we looked at, was depression better, was hopelessness better, and we could find nothing except that one thing. Yeah.
I was wondering if you also considered having a group who received DBT along with an SSRI as an extra group in the study.
Yeah. Yes. We actually had an earlier study where we kind of did that, we actually didn't. We found if you put the two things together, DBT and SSRI, you get kind of a faster treatment response, and that's about it. You don't get any kind of differential impact on suicidal behavior. I mean, it's just, it could be that other, I have to say, I mean, in terms of medications, I don't think that we have, the way that I look at medications for BPD is like, say, there is a target. They're shooting arrows at a target. And there is a center of this target. We just don't know what it is. I mean, I have my ideas about what that center is, but the arrows are going all around the target, and we're just like off. And sometimes we don't even hit the target. But these are what we have available. Yeah.
Question. I'm wondering if we're at that point of shifting from a 12-month to a 6-month period.
So I don't know. I mean, so the question is, are we at the point of switching from 12 months to 6 months? I would say probably not. If you're thinking about, I mean, as I said, I was doing this with specifically targeting suicide outcomes. And so you have cognitive therapy for suicide prevention, which is like 10, 12 sessions. And it's then being compared to DBT that's 12 months long. And it's like, well, who is going to choose DBT over cognitive therapy for suicide prevention if they both have similar outcomes? And so, like, how much can we shrink DBT if we're just interested in preventing suicidal behavior? And so we have some sense that we can do it in a shorter period of time. DBT does much more than that if you think about it from that perspective. And so the reason we chose 6 months is because that's how long it takes us to do one set of skills. I don't know. Alan, any of the DBT folks back there, do you have an opinion about that?
The data tell us that we compile studies that the trajectories don't flatten out after 6 months. So we make a lot of progress in 6 months, but the progress continues in the next 6 months. And actually, sadly, the data say that the progress actually continues decisively. So it's a matter of the severity and what other resources are available for you to stop treatment.
So progress in terms of what?
In terms of returning to work, quality family life, quality social relationships, depression. Of course, it's a kind of a survival analysis. So some people actually after 6 months are great. I mean, the question is, as a whole cohort of patients, that there's enough variability for people to continue to get better.
Yeah, so, okay, so that's kind of the point that I was making. So if I'm targeting suicidal behavior and self-injury, this amount of time, he's talking about other kinds of very important things that other than suicidal behavior.
Other targets in stage 1.
Yeah. The last one quickly, and then we have to go on.
Do you have an opportunity to go back and see for these patients that have gone through the 6 months, the full 6 months?
Yes.
They've gone back into.
We have follow-up data that we haven't looked at yet, yeah. Okay, thank you.